to introduce Professor Otto Kernberg. We thank you very much for accepting our invitation to the psychological services at Tel Aviv University. As you probably know, generations of psychoanalysts and psychoanalytically oriented psychotherapists grew under your writings and teaching, and many of the people present here have read your books, your articles.
Okay.
And almost every week we discuss regarding the personality of organization of patients who come to us, and we feel privileged to have you here with us, and we thank you for that.
So I'll read a short CV, okay? Professor Kernberg was born in Vienna. He and his family fled Nazi Germany in 1939. We were just discussing it at the age of 12 in 1939.
Age of 10.
Sorry, 10, but just at the nick of time, emigrating to Chile. He studied biology and medicine and afterwards psychiatry and psychoanalysis with the Chilean Psychoanalytic Society. He first came to the US in 1959 to study research in psychotherapy. In 1961, he emigrated to the US, joining the C.F. Menninger Memorial Hospital, later to become the director of the hospital. Throughout his career, he held senior key positions in the triangular space of the clinical world of psychiatric hospitals, academic research and investigation, and psychoanalytic training and supervising. He was the supervising and training analyst of the Topeka Institute for Psychoanalysis and director of the psychotherapy research project of Menninger Foundation, Kansas. In 1973, he moved to New York, where he was director of the General Clinical Service of the New York State Psychiatry Institute. In 1974, he was appointed professor of clinical psychiatry at the College of Physicians and Surgeons of Columbia University and training and supervising analyst at the Columbia University Center for Psychoanalytic Training and Research. In 1976, he was appointed as professor of psychiatry at Cornell University and director of the Institute for Personality Disorders Institute at Cornell Medical College, which I was astonished to find out that you are still there until today, 70 hours a week of work until today. He was president of the International Psychoanalytical Association from 1997 to 2001. Your theoretical influences are wide and rich. You've been inspired by Mate Blanco in South America, Frieda from Reifwan and Seals doing psychotherapy in Chestnut Lodge, US, working with psychotics, drive theory by Freud, French analysts like André Green. You attempted to integrate Kleinian and British object relations approach to transference analysis with American ego psychology theory of Margaret Mahler and Edith Jacobson to deepen and enrich the understanding, diagnosis, and treatment of severe personality disorders, which we hope we will hear more of today. Here at the Psychological Services, we cater for all the students on campus. We are a place of training and education in psychotherapy, clinical technique, with an historically psychodynamic orientation, recently making a genuine attempt to incorporate and integrate other evidence-based paradigms like CBT and IPT. Over the last years, we've found that though the student population can be characterized as in their 20s to 40s high in cognitive and mental functioning than the average population, it is no longer right to say that there is little prevalence of personality disorders within the student population. And so we asked our session with you to focus on the assessment and diagnosis of personality organizational structures and personality disorders.
Thank you very much. A very good introduction. You really described the essential influences that have been important in my development. And I'm very pleased with being here and appreciate your appreciation of it. I understand that you are mostly interested in what I have to say about diagnostic evaluation of patients. So that should be a central part of it. And you would like to hear something about transference focused psychotherapy. I I'll be glad to try to do that and leave enough time for discussion. I plan to use my slides, but to talk informally, and feel free to interrupt. Fortunately, it's not too large a group. It's just still possible for any of you to interrupt at any point, raise questions. I'll be glad to do that, and so I can get your interests. Maybe I should just give you very briefly my view about personality theory and personality disorders. I imagine, as you are all psychologists, you have gone through all the training of all the theory, and as these issues are very controversial, there are big fashions that I question, and so it might be helpful so that you know where I come from. What I'm presenting to you is not simply my personal view, but that of the institute. That I have a group of 10, 15 people who have been working together for 30 years on studying psychopathology, diagnosis, theories of personality, and developed a specific treatment. So I'm really bringing a collective group here. You probably know some of the members of that because Michael Stone is our expert on forensic psychiatry, is probably the best forensic psychiatrist in the United States. We have several methodologists for research in personality, John Clarkin, Mark Lenzenberger, Ken Levy, I don't know whether that name says something to you, Diane Diamond, expert in attachment and narcissism, Yves Caligore, a major psychoanalytic theoretician who is writing about general theory of psychoanalytic psychotherapy. A new book will come out at the end of the year. So what I'm bringing together is a general theoretical way of thinking, although of course I identify with it, but I just want to say it's not simply that I'm giving you my own ideas. Okay. We conceive of general personality theory. We conceive of personality as an umbrella concept that includes all psychological functioning, constituted by basic components: temperament, the inborn reactivity of the organism, cognitive, behavioral, affective, mostly affective reactivity. Temperament determining through affects the basic motivational system, affects as basic motivational system that move the baby to enter into contact with mother, inborn facial expression of affect, behavioral expression of affects, subjective experience of affects as positive or negative, specific aspect, specific primary affects, all of which radicate in certain structures of the limbic system with specific neurotransmitters that partly overlap but partly are specific to each affect with a specific facial expression that has communicative value and a subjective experience of pleasure or pain. We move toward pleasure, run away from pain, and that determines the positive and negative affect systems. Positive affect systems: attachment, erotism, play bonding. I don't know whether you're familiar with the contributions of Jörg Panksepp, a major theoretician, neurobiologist who developed the psychology of affect. Essential reading. Okay. each affect, so that the positive affects are attachment, erotism, and play bonding. Attachment, I'm sure you are familiar with recent research and interest. Erotism, strongly neglected, except clinically, particularly by French analysts, and play bonding, representing the general affiliative instinct of friendly interchange with other members of the same species. These are the positive affect system, each of them bunch of affects, and each affect with a component of facial expression, bodily expression, subjective experience, neurovegetative discharge, communicative function, and cognitive framing, because activation of each affect activates at the same time attention function and what is called effortful control by the prefrontal cortex. So each affect activates effort to perceive the environment at the moment of the affect, which comes to constitute a kind of cognitive framing. Negative affects, the fight-flight system, all kind of affects dealing with fighting and determining human aggression and escaping from dangers that cannot be controlled. And then the separation panic system, an emergency system when there's a basic threat to the individual. Very often it's put together with attachment, because when attachment failed, separation panic activates, but separation panic activates when there's an earthquake, when you are in immediate danger of any kind. And probably the clinical syndrome of depression has to do with some abnormality of genetic and constitutional nature of the separation panic system. So affects get involved in the relation between baby and mother, interaction with mother, attuned or not attuned, you know the whole thing about secure, insecure attachment. And here begins our theoretical view, which is contemporary object relations theory in psychoanalysis. We conceive as basic constituents of psychic experience, building upon temperament that I already defined and the interaction motivated by the affective aspect of temperament, the actual interaction with mother or whoever represents her in the form of the experience of an interaction between self and other. And we know that from birth on, there are specialized areas of the prefrontal cortex that focus on one's self-experience, and others, dorsolateral prefrontal cortex, on the perception of the other. So the differentiation between self and other starts already at a primitive level from the beginning of life. So the interaction between self and other is internalized, what in attachment theory is called becoming internal models of behavior. In psychoanalytic object relations theory, dyadic units of self and object representation framed by that common affective experience under which they took place. Internalization is affective memory, primarily located in the hippocampus but distributed throughout the entire cortex. So we have millions of such dyadic systems that get condensed into two major segments, what we call an idealized segment, all the good experiences, good self, a good mother, good self, good others, and separately at first because they happen neurobiologically separately, and eventually because they are psychological mechanisms that keep the good away from the bad, a segment of bad self-experience that we call a persecutory segment of early experience, because by psychological mechanism they tend to see everything that is painful is in the outside to get away from it. There is a projection of all bad experiences seen as representing a dangerous, bad world. So absence of mother becomes a bad mother, so to speak, relating to a suffering self, a typical dyadic situation of the negative kind. Two major segments then of experience that over the first few months and first year of life gradually become integrated because the positive dominate and permit to have a more relaxed view of the things that are bad, and because cognitive development under conditions of low active activation permit to explore the world and add a realistic perspective. So an integration takes place by which then eventually all the self-representations integrate into an integrated sense of self, establishing internal continuity throughout different experiences and throughout time, and integrating the representations of significant others so they become more realistic, not all bad, all good, but normally mixed with the predominance of positive aspect, a more realistic representation of others in our mind. And we call identity, normal identity, the achievement of an integrated sense of self and an integrated world of significant others. At the same time that this happens in the subjective structuring of the mind, behaviorally, the experience in all these interactions determines habitual ways of behavior, habitual behavior patterns that use the accumulated experiences of those million internalized dyadic experiences to establish economic way, practical economic way to relate to the environment. We call character the behavioral manifestation of this habitual behavior pattern. Overall character is the dynamic integration of all these behavior patterns. So we have now temperament, identity, its behavioral manifestation is character, or if you wish, character and its subjective correspondence, identity. And on top of this, we tend to devalue certain general value systems that exceeds what is instrumentally practical in our daily life. It constitutes an internal system of morality. And this has two major components. One, there are certain things we don't do because they are dangerous, we get punished. If we smear caca, if we smear shit on the walls, we get punished. And we learn very early that you don't do this. So that the earliest part of the superego is really that of prohibitions and a moral system based on avoiding punishment, but that gets supplemented, complemented, and overwritten by learning of ways in which people are supposed to relate to each other to improve their mutual understanding, gratify everybody's needs beyond the immediate instrumental situation, positive value systems that constitute the positive aspects of ethics that are constituted by family ethics, as well by the internalization of cultural values. These are the positive aspects of experience. Mother will love me if I behave in a certain way. It's not that I'm going to be punished if I don't, but that will give me extra brownie points, and society will give me extra brownie points if I'm an honest person whose words can be relied upon. And they are different. There's early research indicating there are different aspects of the frontal cortex in which these two different aspects of moral development are located. It's very early. And of course, this is a concept of the superego in psychoanalysis that is constituted by the deepest layer of negative no's, prohibitions, on top of which is developed the ego ideal, the kind of thing we should do so we are loved by those whom we love and feel grateful to. Integration between the no's and how we should be to the higher level superego, the Oedipal period superego with more complex values, and particularly prohibitions against infantile sexuality. Temperament, identity, character, internalized ethical systems, and cognitive capability, mostly a cortical function, intelligence, as we know, 50% genetically determined, inherited, and very importantly influenced by the development of cognitive function, the first few years of life, relationship in which what goes on, in which those who surround the baby and the child are interested in developing thinking of the child and listening to it, in contrast to simply telling the child what to do. So we know there are cultural determinants of intelligence that are very important. That's the personality then. That's all I wanted to say about our theory of the personality based upon, as you can see, psychoanalytic object relations model that I sneaked in, so to speak. Normal personality permits gratifying one's needs, aggressive, sexual, dependent, auto-affirmation, dependency, gratification of sexual, intimate, friendship needs in an harmonious way with the environment. How does it show practically? In that we function well and happily in work and profession, love and sex, social life, and creativity. Now, that sounds pretty trivial, but practically, these are the three areas we have to investigate in diagnosis, in depth, in the initial interviews. This is a radical opposition to the kind of traditional history taking. First you want to know your grandfather was a railroad engineer in Russia, and then you go through, by the time you get to the present, there's almost no information, and no information helpful for diagnosis nor for treatment. I'm exaggerating a little, but that's a major problem. We start out looking into how are you doing now in work and profession, love and sex, social life, creativity. If we wake up our students at night and we say, what are the most important things to investigate? Work and profession, love and sex, social life, creativity. What are personality disorders? Rigidification of the system. The most important characteristic of personality. Here I'm quoting the contributions by one of our theoreticians, Eve Caligore. You probably have never heard her name, or maybe some psychoanalysts have. She has been a very important part of our theoretical study group. The most important aspects of personality disorder is rigidification of the character, which means the individual develops rigid, habitual ways that are applied, whether they fit or whether they don't fit, the loss of normal flexibility. And at what point are these ordinary quirks? All of us have some kind of rigidity. So at what point does it become a personality disorder? That has never been clarified. It's clinical judgment. There is no strict rule, and the effort to say, oh, if you have 3 symptoms, if you any effort to quantify that so far has been useless. It's a clinical judgment, sorry to tell you. At a certain, but clinically not difficult to assess if you look at these major areas of functioning. And what's interesting is that these rigidifications come in certain constellations, certain traits that get together, rigidified, and determine the most important aspect, personality disorders that we know clinically. The obsessive compulsive personality, the hysterical personality, the depressive masochistic personality, etc. The rigidification can be classified into 3 types. Inhibition of certain behaviors. The rigidity implies inhibition. Exaggeration of certain behaviors, what's called reaction formation in psychoanalytic lingo. Or chaotic alternation between inhibition and exaggeration. The more severe the personality disorders, the more the chaotic combination of inhibition and exaggeration combine. The healthier ones are usually mostly inhibitory and exaggeration, but not chaotic expression of contradictory character traits, which already indicate severity. That is a quantitative, simple criteria telling somebody he is more or less sick. But a more scientific one, and here comes the contribution of our institute, which we developed about 30 years ago, and the psychiatric committees of the international classification ICD-10, ICD, and the DSM system, after 30 years were able to incorporate these complex ideas that we developed. Reason, not mental retardation on the part of the committees of the European and American psychiatric, just ideology, because character and personality come so close to issues of psychological existence that they are prone to be politically grabbed and distorted. I can't go into the more concrete. I think that's the main reason. When I talk about politics, there was an opposition to the diagnosis of masochistic structure because it's supposed to be directed against the women. So they changed it to self-defeating, but that's a euphemism, so they eliminated. Economic reason, the affective disorders, people wanted to grab everything having to do with depression, so the depressive personality was not the personality disorder anymore. And then there are the social psychologists who are interested in the degree of affiliation, dominance, and submission, and want to classify personality on the basis of such traits, in contrast to the epidemiologists who want to study all the character traits that exist, the 150, develop 50 tests, examine 50,000 persons in the population, and come up with the magic hair, the 5-factor system. I'm sure you have all been trained in them. The 5-factor system that indicate the dominant traits in large populations as evaluated by multiple instruments. And it was supposed that these have to do with the personality disorder. So the personality disorders have to be configured so they fit into this finding regarding the functioning of large populations on the basis of multiple tests. This mental acrobacy is still in control of ground segments of the psychological and psychiatric literature, and has been very influential. Is one more reason for the conflicts regarding classification of personality disorders. And of course, then there come the neurobiologists who want to classify personalities in terms of dominant affect systems as determined neurobiologically, Cloninger. And finally come the psychoanalysts who are interested in unconscious determinants of behavior, and the original psychoanalytic classification. What we have done in my institute is trying to combine what we see clinically, what's frequent concretely clinically, with the development in our knowledge of neurobiology, and with the careful study of intrapsychic structures underneath the specific symptoms of the various clinically observable behavior patterns. So we came in suggesting, and I'm sure that you all know what I'm going to say, that the fundamental criteria of severity of personality disorder is the extent to which there has been an achievement of an integration of identity, integration of the concept of self, integration of the concept of significant others, or not. If you have severe character distortions, but with a good, solid identity, I repeat, the definition of identity is not only integration of the self, but integration of the concept of significant others. Is that combination? If that has been achieved, then you have what we call neurotic personality organization. Personality disorder with identity normal, high level, the hysterical, obsessive compulsive, depressive, masochistic personalities usually fit into that overall structure. And then we have borderline personality organization, not to be confused with borderline personality disorder, that shows severe characterological patterns and lack of integration of the concept of self, lack of integration of the concept of significant others, identity diffusion. And finally, there are structures in which not only are severe distortions of behavior, but there is a loss of reality testing. Reality testing, as you know, is the capacity to differentiate self from non-self, internal from external origin of stimuli, and the capacity to maintain empathy with ordinary social criteria of reality, which depends upon the social background. If everybody in your culture believes that if you put a needle through a photograph, the person of that photograph is going to either die or have an illness. If everybody believes that it's part of reality testing, of course, if I pinch a photograph, well, naturally, we know that what's going to happen. Everybody knows that. So you have to evaluate reality testing in a cultural context. If reality testing is lost, then what we have is really a lack of differentiation, a deep lack of differentiation between self and others. And we are no longer in the territory of personality disorders where we have atypical psychotic syndromes. It's an easy, elegant differential diagnosis of psychosis from severe personality disorders, or an organic brain syndrome in which reality testing is lost as an advanced degree of the cognitive deterioration, dementia, either severe form of mental retardation or dementia, but these are not so-called psychotic personality structure. In that regard, is a misnomer. Is everything clear so far? Okay. On that basis, we try to diagnose patients who come to see us and make diagnosis of personality disorders.
But what about differences?
Yeah.
About defense mechanisms. You didn't
Yeah. By the way, let me do something here. I have a hearing difficulty, serious hearing difficulty, and I have a wonderful thing. This is not a tape recorder. It's called a Roger pen, and it is a microphone connected with a receiver that increases my purpose, so I'm using it as part of this discussion. So I'm not taping you. What were you asking?
I'm not sure if I heard if you mentioned the defense
Yes,
organization.
very good point. In this brief summary, I did not spell out the fact that when identity is not achieved, that original, yeah, thank you, yes, I was aware of that. I will protect it further. I think that's it. Doesn't do it. The original separate channels of positive and negative affect is reinforced by the psychological mechanism of splitting and projective identification. More generally, the predominance of splitting mechanism and related projective identification, denial, omnipotence, omnipotent control, primitive idealization, devaluation, the set of early defensive mechanisms described by Melanie Klein are typical for the normal primitive level of functioning, or when the individual is fixated at that level, for the predominance of those defensive operations in the case of borderline personality organization, severe personality disorder. In contrast, when identity is consolidated, there starts a predominance of the classical mechanism of repression, the elimination from consciousness of intolerable contents of mental desire and fears. And repression, in turn, is reinforced by a set of related mechanisms that include negation, intellectualization, rationalization, reaction formation, higher forms of idealization and projection. So, from that viewpoint, in the diagnosis of patients, what happens, those who are healthier with the predominance of repression don't show these mechanisms in the interaction. The higher level mechanisms show during treatment when there's an effort to get to unconscious conflicts, but not in diagnostic interviews. The primitive defenses always have behavioral manifestations. They show and they contribute to the diagnosis. They are not essential, but they are contributing. So that's a very important clarification. Any other question or clarification before I go into the interview? Is that sure? Yeah,
Maybe you can elaborate about the way of you assess the identity organization.
I will do that as part. That's what I'm going to do right now. So we developed a method called structural interview, which is it's really a modification of the classical mental status examination, enriched by what it takes to make a differential diagnosis of personality disorders. It is extremely helpful. The problem we have that psychologists and psychiatrists are first trained in classical models of studying each function in a non-integrated way and not study several others that we have added. So it takes relearning. What we tell our students is just keep this in mind. Once you have more practice clinically, it will be easy to do it that way. But for the time being, just continue doing what you're doing. We try to avoid the confusion of getting from one, so what we prefer that each of our trainees maintain whatever they've learned and just keep this in mind for a later stage where they feel already comfortable, and by the same token, then this becomes easier. So I'm saying the same to you. I don't know what your training is. I don't know anything at all about you. Perhaps this is what you're doing anyhow. And maybe I should, before I start, ask you, who of you have studied the structural interview? Raise your hands. So it's a minority. Okay, good. That gives me a good feeling. I hate to teach things that everybody knows. It's terrible. The same happens. It is usually very helpful if one does psychoanalytic psychotherapy or psychoanalysis to have had a treatment oneself. And we tell people it's a very good self-experience. But it is not indispensable. It's not. There are some people who, without any psychotherapeutic experience, do things, understand everything from the beginning. This is always frightening to us when somebody knows what to do without having gone through the training. So if you know that, try to hide it, because it's okay. The structural interview. It takes at a minimum 45 minutes, which we do. We have a double session, usually an hour and a half, that we give ourselves for doing this kind of interview. In easy cases, that's enough to reach a diagnosis. Sometimes there are difficult cases where we need 2 or 3 of these. And there's a very small proportion of cases where the doubts persist. I will mention to you which those cases are. We start where it says enter. Is that? Yeah. No. No, we keep that. By the way,
Enter on the left-hand side of the...
there is, do you have a laser?
Not here.
No? Oh, that's, yeah, right. Okay, wonderful. We start, first of all, we tell the patient everything we know. I say, I'm Dr. Kernberg, I'm here, I've been asked to see you, whatever. All I know about you is that you are Mr. or Mrs. So-and-so, and that you are 50 years old or whatever. We try to tell the patient whatever we know about the patient in ways that the patient can understand, and so that we already convey from the beginning a kind of open communication with the patient. And we ask the patient, I would like to know. I have the following question. I would like you to tell me what brought you here. What's the nature of your difficulties? What do you expect from treatment? In short, where are you now? So we do 4 questions together. What brought you here? What's the nature of your difficulties? What do you expect from treatment? Where are you now? You notice that we go from something very concrete, what brought you here, to becoming more and more abstract. What's the nature of your difficulties? What do you expect from treatment? Where are you now? This permits to immediately test severity of illness, in that the sickest patients, psychotic patients, tend to get disorganized by the questions that are not very concrete. A well-functioning patient is perfectly able to deal with all of this. The patient has to be attentive, has to be able to have immediate sufficient memory and understanding what we are asking. So it's a mini test of memory and intelligence, and at the same time, of course, of the sensorium, attention, orientation, degree of consciousness, judgment. So it is already a mini examination that is also influenced by all kinds of defensive mechanisms. A patient may say, "Oh, my mother brought me here." We already raised a question about cognitive control and level, etc. Or a patient may say, "Well, you know, when I was 7 years old, I was raped by my father, and I have been raped then at age 13 and 17. So the patient comes already with etiology all wrapped up. So we tell the patient, I'm sure this is important, we'll have time to talk about it, but do you remember my questions? And we go back to, or we may have a patient may say, yes, I remember your question, but I wanted we should go to what's essential. And we tell him, I appreciate your wish to go to essential. I understand your concern about this, but I really need to know, do you really remember? Can you tell me the question that I asked you? And the patient will say, of course. Okay, so what brought you here? We go back and ask the patient for symptoms. And we ask the patient, if the patient then goes on and describes all other kind of difficulties, we just listen, and the patient then talks about what he expects from treatment. A patient may really answer us, which is quite a feat, and we can then deepen various areas. And deepening signifies first, regarding what brought the patient and what's the nature of the difficulty. We try to carefully ask for all symptoms at this point: physical, emotional, behavioral, social. And once the patient stops, we ask the patient, if you didn't have any of the things that you told me so far, would you be all right? Patient may say, well, who is all right? I say, well, would you be like the average person who doesn't need to see a psychiatrist? And the patient would say, yeah. So then we know we have all the symptoms and difficulties. Symptoms change, and to have a very clear and complete information at the beginning of the treatment is extremely helpful in all cases. Of course, there are patients with multiple conversion symptoms who can give you, or patients with hypochondriasis, which is a severe form of personality disorder, true hypochondriasis, and who give you symptoms, I have this and that and that and that. They say, and in the past I had that, and we say, well, now we want to know what you have now, what you are suffering now. So we try to get a very complete symptom list, and to make immediate differential diagnosis. Patient says, and to try to get away from professional lingo. Patients who come and say, I have a borderline personality disorder. We tell the patient, what do you mean by that? What do you mean? What do you feel? What are the difficulties? So the patient says, I'm paranoid. What do you mean by that you're paranoid? I've been told I'm paranoid. I understand that, but what is it that you feel? Or what is it that bothers you that you would kind of label in this way. So we try to get the real experience, and not particular patients who have been seen by many other people start reciting to us our classification system, where we try to get out of that. Once we have that full information, and only once we have that, we go on to asking the patient about his personality. This, we go around the circle. If you, oh, is that? Oh,
Yes, it works.
yeah, great. Okay, oh, that's great. So we move toward asking about the present personality. We tell the patient, now I would like to know about your present life. First of all, do you work? Do you study? What do you do? We try to know what's the, of course it depends how, if we have a 13-year-old, we want to know how he's doing at school, of course. If you have a 30-year-old, you want to know about work situation. What's the work of the patient? How is the patient functioning? Is the patient satisfied? Is the patient doing well? Does the patient have difficulties? How does he get along with co-workers, with superiors, with subordinates? How does it fit with his education? Is he working at the level at which the patient was trained or not? Is he stable in his work? Has he been losing work? So that we are trying to get full information about efficiency, satisfaction, and the social life around work. Very often you find a woman tells you, oh yes, I have a master's in special education, and I have a master's in 17th century French literature, and I work at a flower shop. So there is a discrepancy, and so I would immediately ask, so how come with those two masters you work at a flower shop? What has happened? So we try complete information what is going on, the functioning at work and profession. And something extremely important is the two prognostically most important negative indicators for all kind of psychotherapy are antisocial behavior and secondary gain of illness. Secondary gain of illness means exploitation of one's pathology for obtaining secondary benefits from the family or the state. It is a development of a kind of socially fostered passivity that becomes a highly invested motivational system and operates against the treatment. I don't know whether you have the problem in Israel, but it certainly exists in the United States that people who have personality disorders find reasons not to work and be in a chronic dependent situation of the family or of the state. And we have a big, huge state organizations that help such patients who get anxious every time they work. They feel fine as long as they don't work. I remember a patient I saw in Finland who wasn't working, who was a philosopher, and he was being paid disability. He would go in the mornings to the park and read philosophy. He had a happy life, sustained by the state, was in treatment for about 8 years without any change. So the diagnosis was he was sick, but no fool. And so we are interested in the problem of work because as part of at least Transference Focused Psychotherapy, we expect all our patients to be fully occupied, studying, working, we give them several months, but make it as a condition of treatment. This is a little note on treatment, but it's important. Remember secondary gain, and of course, the more severe antisocial feature, the worse the prognosis. After asking about work, we ask patients about love and sex. Are the patient have the, again, of course, if you have a 13-year-old boy won't ask the same thing than of a 40-year-old man or woman. We ask the patient whether they have a partner, whether they are in love, whether they have a relationship, have they ever had a relationship, is their relationship stable, is it satisfactory, do they have severe conflicts, are they very unstable in their relationships, what are the problems that they have. We want to know, are they predominantly heterosexual or homosexual, or not clear whether they are predominantly heterosexual or homosexual. We find now in severe adolescence there is a fashion in the United States to be transsexual, multisexual, and people with severe problems in their interaction explain it that they are really very free and don't want to they are asexual, they want to not to identify with any gender and feel free to have sex with whatever. We don't ask them whether they enjoy sex with animals, but of course rarely we find problems in that regard as well. So we want to know, but what most interests us is whether they are able to fall in love, to love, whether they are able to connect their sexual wishes with tenderness, so love and sex go together, or whether they are split and they are capable of having sexual relation but incapable of any love relation, or have intense love relation with severe sexual inhibition. We try to find out about sexual functioning, whether there is sexual inhibition in men and in women, if necessary, we try to find out what frequency their sex is. In any case, we find out whether they have the capacity of reaching orgasm in intercourse or not, and with what frequency they have sex. That becomes very important with some very inhibited sexual people. There is questions about sexuality are socially, culturally dealing with more intimate and difficult to talk about subjects. Many therapists feel reluctant at first to ask about the sexual life of patients. The freer the therapist internally, or the more experience you have, the easier it will become to ask about the sexual life of patient. It's extremely important. Of course, patients have no couple, or their experience are masturbatory experiences, so we want to know how frequently do they masturbate, with what kind of fantasy. Masturbatory fantasies are important window to psychological conflicts in the area of sex. We frequently find individuals who are totally inhibited socially in their whole sexual activities on the internet. They'll sit for hours and masturbate on the computer, or have relations exclusively by computer, by internet. So we try to find out about all forms and type of sexual difficulties, including, and if patients say, this is too intimate, about this I don't want to talk, we ask the patient what prevents them, what is the problem. We assume there's a serious sexual inhibition going on. And of course, the attitude of the person is important. If somebody feels ashamed, afraid, and doesn't dare to talk about sex, it's very different from somebody who tells us in an attitude of defiance about this, I won't talk, this is too personal, giving the impression that there's some ideological element or paranoid element. And sometimes when we have a sense that an individual is strongly refusing to give us information in general, we tell the patient, it sounds as if it's difficult for you to talk openly to me. Perhaps it's not clear to you what's preferable. to be open to me and see whether I can help you, or keep your privacy. And you should feel free. If you wish, we can stop the interview and you can think it over again at a later date whether you want to be examined psychologically. But you should know that if you want to be helped psychologically, you have to be prepared to be very open about everything. So you have to decide whether whatever makes you suffer is serious enough to make it worthwhile to have such a completely open discussion. Of course, you have to select whom you want to trust to talk very openly about yourself. Maybe it may be easier with somebody else rather than me. So we open the possibility of ending if the patient is not willing to be sufficiently open to give us full information. So we ask very clearly, and this is an area which is horribly neglected in practice. In that regard, the puritanical issues, and particularly in the United States, have an influence on the way people work. From pathological character traits, we go then to the next item, which is the study of identity. Now I'm going to answer your question. We now ask the patient, we say, now I would like to know something about the people who are most important in your present life. Very often patients have already mentioned their boss, a sister, a boyfriend, a wife, mother. So we ask the patient, can you describe to me in a few minutes the personality of that close person? So I get a live picture of how that person is. What makes it, him or her, different from everybody else? What's unique about them? What do you think are the essential aspects? It's a difficult test for the patient, and patients have to think. And of course, some patients give you immediately an answer without any thought, some superficial generality, and you listen to what they have to say, and then you ask them the same about one or two more persons. And you immediately can see whether you get the general same description of everybody else, cliché statements, or to what extent you get differentiated descriptions by which you can imagine different people. You may patient may say, oh, he or she is a very nice person, great fun, it's great fun. The next one, oh, great person, great fun. All three are great fun. Or you may get a chaotic description. My mother, she's very loving, and she gets enraged and is intolerant, but she takes good care of us, is never at home. And so you get, if you get a clearly contradictory thing, you'll say, you've told me things that sound very contradictory. Did I hear you right? So you can see to what extent the patient is confused by your being confused, is not aware of the fact that she's a victim to contradiction, which already indicates serious problems in evaluating others. Or the patient may say, you're absolutely right, she's totally contradictory, you never know, is not a person of whom you can tell where do they stand because of this contradictory behavior, which is terribly irritating. Here, this is evaluated as a problem, so you see a very different attitude. So you try to get the description of 2 or 3 people. Once you have done that, and I'll come back how you judge whether this is within normality or not. Then, and only then, you tell them, now I want you to describe yourself as a person. What makes you different from everybody else? What do you think is essential about your personality that I should know? And of course, you already have observed the person, so you already have your own impression, so you can see something about the capacity for introspection. And the patient has learned already about thinking about others, so it's easier to apply to himself. So it has to be done in that order. And again, now you can get a picture in some depth or a completely empty, contradictory description, or an total incapacity to say anything about themselves. This is the most difficult part of the structural interview. The way we teach it is a complicated mechanism that takes several weeks, but we found it's the best way to teach it. We ask each of our students to raise these questions with a group of their friends, telling them they are learning to study how to study personality. Would the friends mind if they ask them just two easy questions? One, to describe the most important people in their present life, and then themselves. And so we ask people to do that. We assume that most of the friends of our students are relatively normal. And at the same time, we ask them to do this with our hospitalized severe personality disorders, all of whom present severe identity diffusion. You do that for a few weeks and you get a clear sense of it. Of course, it helps if you hear about concrete cases. We don't have time for that now. But the method takes more time because it's complicated, but practically it's not too difficult to make that judgment once you've had that empirical experience. If you try to do it yourself, try to describe to yourself the essential persons in your life and what you think essential about yourself. Write it down on a piece of paper, look at it later. You'll see what's involved and what the crucial issues are that may make the differentiation. If there is identity diffusion, lack of an integrated identity, signifies severe personality disorder or borderline personality organization, and that covers the majority of the clinical syndromes, including, and here I can show that to you on our general. This is our own classification of personality disorder. It has more personality disorders than the official classification because the official classification leaves some things out or have not yet been integrated. The hypochondriasis is left out. The syndrome of malignant narcissism, which are now in the United States has become extremely important for political reasons, is being considered, etc. So here is the classification. This combines both temperamental and psychodynamic issues. Thank you. Here on top, you have neurotic personality organization, introverted and extroverted. This is the introverted pole, extroverted pole. You have the obsessive compulsive on the introverted, depressive masochistic close by, and hysterical on the extroverted. Below that is all borderline personality organization. Again, introverted, extroverted. These are the milder ones, and these are the more severe ones. The differentiation is that milder personality disorders are still able to function in work and profession, love and sex, social life, but with serious difficulties. At this level, there are already serious difficulties of both establishing dependent relationships, stable love relation, and at work. These are serious and generally disturbing to the patient and the environment. On the introverted, we have problem with the diagnosis of avoidant. I think it's a problematic category. The depressive masochistic personalities are related to the dependent. Sadomasochistic are more severely depressive masochistic personality, in which the sadistic elements begins to show. In general, as we go down, there's a predominance of conflicts around aggression, in contrast to predominance of conflicts around edible sexuality at this upper level. And here there's a mixture, but there are always mixture with edible issues, but aggression is strongly predominant. The paranoid personality, the schizoid, and the schizotypal, which is a more severe form of it. Hypochondriasis, a rare but important syndrome, excessive preoccupation with physical illness, hypersensitivity to perception from one's body, health rituals, food rituals, replacement of object relations by concern with one's own body. On the extroverted side, so the typical introverted one is the schizoid personality. On the borderline personality disorder, on the extroverted one, the histrionic personality has, the histrionic personality is a regressive form of the hysteric. The narcissistic personality is a special complication whose most severe form is the syndrome of malignant narcissism, and related, of course, the antisocial personality proper, with strict criteria given by Hare, Stone, myself, does not respond at all to any psychotherapeutic treatment. The prognosis here is 0. This is the most severe personality disorder. All others are treatable. Okay, so that's in a nutshell the predominant syndrome, which emerge very naturally in the oh, this doesn't work. Oh, that's here, in the structural interview. After having evaluated, so identity disturbance usually means that that you find the pathology not up here, but somewhere over here, and the severity of paranoid features and or schizoid isolation is very typical, and here the behavioral manifestations of impulsivity, dramatic behaviors, and severe difficulties with other people. Here there's more social isolation. Here there are active and aggressive and self-destructive interactions with others. We then explore reality testing. After having studied identity, and as long as the patient has not revealed that the patient, if the patient from the very beginning, if the patient from the very beginning seems, the patient comes in, we ask him, what brings you here? And the patient tells us, I'm the Messiah, I'm here to save the world. We tell the patient, are you certain? And the patient says, those who doubt will have a chance to learn the truth. And the patient is dead serious. You have a psychotic patient. And so in that case, you immediately go into study his behavior, his affects, his thought, whether he has hallucinations or delusion. You make sure that the sensorium is functioning well, attention, orientation, consciousness, comprehension. You study memory and intelligence. In other words, you use traditional psychiatric examination if the patient, or if the patient is clearly organic. You ask the patient, what brings you here? The patient says, well, I was asked to see you. Are you Dr. So-and-so? You are the one I'm supposed to see. And you ask him, so what are your difficulties? Problems with my wife. What kind of problems? Well, you see, I told her that the breakfast should, the coffee should be warm enough. What made you decide to come here to see me in relation to what problem with your wife? Well, she said I should come. I think you get the point. If you see somebody is grossly organic, failure of memory, failure of cognitive functions, obviously loss of reality testing, then you do a standard examination for an organic patient. So the structural interview, the first 4 questions already orient you whether you have somebody, whether it's relevant to study personality. So at this point in the interview, you tell the patient, in case you have discovered anything that seemed to you strange in the patient's behavior, in the patient's affect, in the patient's thought content, in the way the patient talks, anything that seems somehow flaky, slightly cuckoo, and you can't put your finger on it, but something made you feel that patient wasn't quite with it. At this point, you tell them, as we were talking, I had the impression that, and you tell the patient what it is that seemed strange to you. And you tell the patient, that seemed strange to me, or puzzling or strange. Can you see that? And if the patient has preserved reality testing, he's able to see what you're telling him you saw and seemed strange. In other words, you are testing the presence of the capacity of empathy with social criteria of reality that you are representing at that point. Of course, if the patient has told you in the middle of this that a patient has hallucinations or delusions that would indicate loss of reality testing, you may have the answer earlier. And in this regard, let me remind you that true hallucinations and true delusions indicate psychotic functioning, in contrast to, far as perception are concerned, illusions that may be present with personality disorders, and pseudo hallucinations. Are you familiar with the concept of pseudo hallucinations? Yes, no? Yes, no? Pseudo hallucinations are false perceptions that the patient places in his subjective space rather than considering them corresponding to objective reality. Example, the patient says, and then at night I saw the Virgin Mary. She was standing in the corner. Was the Virgin Mary there? No, of course not. I could look through her. It was an image I had, but it was an image. I knew it came from me, but it was kind of frightening. That's a pseudo hallucination. I heard this voice of my mother. I really heard it. So what does it mean? was your mother talking to you? No, I know I was imagining that, but it had a quality of reality that was kind of frightening. These are pseudo hallucinations in which reality testing is maintained. That you can find with severe personality disorders. Not true hallucinations. Yes, the Virgin Mary was there. I don't know why I've been selected. My mother, what do you mean? Yes, she was talking to me. She knows who I am, and when I'm with my boyfriend, I know she knows. I know. That's a different kind of quality. Obsessive ideas, of course, the patient knows they're completely unreal. A patient of mine, while his parents would go to church, L would use the Sunday morning to have sex with his girlfriend at home. But it was very frightening because he thought that Jesus was looking at him with tears in his eyes. And said, is Jesus really looking at you with tears in his eyes? He said, no, I know that this is a fantasy, but it was so strong, it inhibited me from having sex. This is a pseudo hallucination, clear reality testing. So if reality testing is maintained, then you know it is a personality disorder, you know its level of severity, and usually you can already know the main characteristics of it. In extreme cases that are difficult, patients who have very strong paranoid personalities, the differential diagnosis with paranoid psychosis can be difficult because the patient knows that if he says he believes what he's saying, you will think he's psychotic, so he better don't tell you. So with severely paranoid personalities, it may be difficult and may require indirect evidence from other aspects of the mental status examination. In the case of, and this is particularly true with patients that have severe antisocial personality, severe aggressive types of antisocial personality, and where sometimes the differential diagnosis is difficult. These are extreme cases. Example, a man asked a man who serious conflicts with father, a very wealthy father, he asked a member of the mafia to have his father killed. So he hired somebody, paid him $10,000, who was going to kill his father. The man was caught, confessed. The police went to the patient who confessed that he had given him $10,000 to kill his father. And so the question was raised, is this an antisocial personality disorder, paranoid psychotic illness? And the patient was extremely reluctant to give information, intense paranoid attitude that he couldn't assess, that he was totally egocentric. It was hard to know to what extent it was a way to hide the fact that he simply had the intention of having his father killed to inherit, and was pretending to be psychotic, or to what extent there was a paranoid psychosis. He was hospitalized for a month at Chestnut Lodge, a specialized psychiatric clinic, who are usually very good diagnostically. They couldn't assess him, sent him to me. I saw him several times. I couldn't diagnose him. Just to give an example. They are rare examples, fortunately, but usually in those cases, psychological testing may be very helpful, particularly Rorschach testing in good hands, and observation throughout time. but it is not a 100% perfect interview. Practically in 95% of cases, you reach a better diagnosis than with any other diagnostic method. We see many patients with antisocial behavior. Maybe it would help to you if I give you our list of severity of antisocial behavior, because it's one of the prognostic most important criteria, as you remember, together with secondary gain. So let me give this to you. I don't have that on the slides. I'm going from most severe to least severe. Most severe, extremely rare, pseudo-psychopathic schizophrenia. These are chronically schizophrenic patients with severe, bizarre aggression. You treat them with medication, the psychosis clears up, and they end up with aggressive or passive parasitic antisocial behavior. You don't know what's worse. You hospitalize them, treat them, they function perfectly normal in the hospital. You let them go outside, one crime after another. They need permanent hospitalization. Rare cases, the most untreatable, most severe ones. Second category, frequent, importance. The antisocial personality proper. All these patients, 90% of these patients have narcissistic personalities plus chronic antisocial behavior, passive parasitic or aggressive. Aggressive, passive parasitic means chronic liars, manipulators, thieves, false checks, irresponsibility for money, exploitation. That's the passive parasitic. The aggressive one, chronic attacks on property, attacks on people, murder, sexual murder, serial murder. So these are extremely dangerous persons who need probably permanent hospitalization in specialized hospitals, usually in charge of the criminal system. It is what is characteristic of the antisocial personality is total incapacity for guilt feelings, total incapacity for investing in any human relationship, total incapacity, as I already mentioned, guilt, concern, and can't even care for a pet that they may have, chronic antisocial behavior, incapacity to learn from experience, zero conception of the future. So very often they get caught because they can only think about their immediate criminal activity, not about the long-range effects on it. The diagnosis usually requires a diagnosis of the total life of the patient. Structural interviews are not enough, given their dishonesty, for really making this differential diagnosis with the next category that is treatable, and that's the syndrome of malignant narcissism, consisting in severe narcissistic personality with severe paranoid features, egocentric, aggressive behavior towards self and others, narcissistic personality, egocentric aggression, and severe paranoid behavior and antisocial behavior. These are the four symptoms. Narcissistic personality, extreme aggression against self or others, strong paranoid features, chronic antisocial behavior. You find that in two categories. At a very severe level of functioning, these are usually confused with ordinary borderline patients with borderline personality disorder, except once you see the grandiosity, what's typical for narcissistic personalities. And then there are some functioning much better with a much better put together pathological grandiose self, and then you find them as political leaders of extreme movement. Hitler, Stalin had typical Idi Amin syndrome of malignant narcissism, not Franco, Mussolini. Mussolini was a narcissistic personality, but without these features. So, syndrome of malignant narcissism. This next category with better prognosis are narcissistic personalities with antisocial behavior, but without the extreme aggression nor the paranoid features. Next category, all other severe personality disorders with antisocial behavior, but not narcissistic personalities. There the prognosis gets better. Next category, neurotic personality organization with antisocial behavior. These are the cases that Freud described as criminals out of unconscious guilt. It's an important category because there is antisocial behavior, but there's a typical neurotic structure, well put together identity, good prognosis. The next category, antisocial behavior in adolescence, is part of adjustment reactions of adolescents, or is part of adolescents who are part of antisocial subgroups, the so-called dissocial syndrome of the British authors. And finally, antisocial behavior of people who steal because they're hungry, no psychopathology, but social pathology. I hope I've not run this too fast, but it is very helpful in terms of prognosis for people with antisocial behavior. Okay, that's all I wanted to say about structural interviewing. We still have about 15 minutes, and I could tell you in a nutshell about transference focused psychotherapy, but really in a nutshell. Or if you prefer to discuss what we've talked, whatever you wish. What do you think?
We should talk about transference focused
Okay.
therapy because it comes out of all of this.
Yeah,
that you've just
okay,
done.
okay. Here is the basic object relation dyad, the primitive split between idealized and persecutory relation, normal integration identity. So what the severe personalities have in common is they get fixated at this early stage. Okay, I guess all of you know what transference is. Transference focused psychotherapy can be divided into strategies, techniques, and tactics. Strategies. The strategy consists essentially in 3 steps. The overall objective is to normalize identity, and with it normalize the whole personality structures. We are not after the symptoms, we are after the personality structure. And the way this is achieved is letting emerge in the treatment the primitive split, idealized and persecutory transferences. And in each case, we try to analyze in these primitive transferences that are the replication in the treatment of these mutually split internalized object relations. What's the nature of an affective interaction that's taking place? Who is who in this interaction? Who, patient and therapist, who represents self, who represents the object of the particular internalized relationship? We tried first step, what's the predominant nature of the interaction? Hostile, loving, dependent, sexualized, whatever. As concretely as we can put into a metaphorical description of the interaction. That's the first step. Second step, who in this interaction represents the patient's infantile self component, who represents the object. One might think the patient enacts his self while projecting the object onto the therapist, but it's typical that patient interchange self and object quickly. So we have to diagnose who is self and who is object in the interaction. As we do that, we permit the patient to accept their conscious identification with both self and object. Let me give an example. A patient has had severe sexual conflicts of sexual violence, sexual attack by a parental object, by a woman who has been sexually assaulted for several years by a psychopathic father or alcoholic father. So the trauma is repeated in that the patient may feel the therapist is going to assault her sexually, is dangerous, and the patient is frightened to death, which may change with the patient becoming extremely sexually provocative, and the therapist has to get into protecting himself. All our research sessions are videotaped. I mean, all our research projects. We have a session where a patient violently tries to sexually attack the therapist, one of our best therapists, with the video going, tears his shirt off, starts kissing him, or trying to while he is trying to protect himself. So we analyze the patient's identification with self and object as they are interchanged. And we do this in the persecutory segment and in the idealized segment. For example, a patient who, on the one hand, wanted me to be like a perfect mother, had the fantasy I was a kangaroo with a pouch, and she was baby kangaroo sitting in my pouch, and she was safe. And at other moments, at one point I had a real crisis that she knew because my house burned down, it was in the newspapers, and the patient came, a very violent patient usually, with a huge bunch of flowers and trying to take care of me, and what could she do to soothe me. And she became like a protective mother, and I was the little baby who needed support. So we analyze in the idealized segment and in the persecutory segment the interaction to a point where the patient becomes able to tolerate identification with self and other in both those segments. And then, third step, we interpret integratively the split. For example, one patient who had been severely abused by her mother in an advanced stage of the treatment wanted me and her have red telephones, like the President of the United States and the Secretary General of the Communist Party of the Soviet Union, to prevent atomic war. And she felt if we both had that red telephone, then she could call me at any point, and I would stop doing what I was doing, whether I was teaching or sleeping or having sex or reading or playing football, I would stop to talk with her. She would be perfectly all right. No more pathology. And I said that that was normal for a 3-month-old child, perfectly normal. She said, I'm not 3 months. She was a 24-year-old woman at this point. And I said, well, I know in one part, but it is as if you can only accept a relation with me like a 3-month-old, in other words, like a baby who feels it has the right to have mother all the time, because the moment I'm not the perfect mother, I become the horrible mother who beat you up. So you have to, you see, I interpreted how she needed a perfect me through that telephone to protect herself against the horrible me. This patient at other points had attacked me in brutal ways. And so this interpretation brought together the persecutory and the idealized segment, and permitted her to realize how she was only tolerating idealized relationship to protect herself against the fear of persecutory one. That, in a nutshell, is the overall strategy of the treatment. Techniques. The techniques are the 4 essential techniques of psychoanalysis. I don't have time here to talk about that extensively, but what we have done in my institute is to synthesize the entire body of psychoanalytic techniques, studied each of them in detail, and concluded that there are 4 basic techniques, that all other aspects of psychoanalytic techniques are combinations of these 4 or applications of these 4. And these 4 techniques are interpretation, transference analysis, technical neutrality, and countertransference utilization. These 4 are our basic techniques. Interpretation, basically like in psychoanalysis. Transference analysis, basically like in psychoanalysis, with the exception that what we analyze are these particular relations that are typical, that I mentioned to you, the split internalized object relations, typical for severe psychopathology. Technical neutrality, which means a concerned objectivity, but that is disrupted in our technique whenever the patient needs the treatment to be structuralized to protect the patient, the life of the patient, the life of others, the structure of the treatment. So we avoid, for example, that patients become violent and destroy aspects of the office or attack the therapist sexually. I had one patient come in one day without underwear, spreading her legs, and so I had to tell her, this is an inappropriate way to come to a psychotherapy session. We interrupt the session now. I expect you the next session to come dressed in a socially appropriate way. That's not technical neutrality. So we disrupt technical neutrality, and then we reinstate it interpretively throughout time. Important difference with psychoanalysis. In the utilization of countertransference, both concordant and complementary. Are you familiar with the concept? Yes. It becomes a very important aspect of the treatment. There are, these are the essential techniques of transference focused psychotherapy, with particular modifications that differentiate them from their use in psychoanalysis. Tactics, finally, refers to specific intervention that deal with a specific situation in the transference of severe personality disorders. For example, the principle of intervening there, what we consider affectively dominance. We intervene where there is affectively dominance. How do we judge affective dominance? By a combined study of verbal communication, non-verbal communication, and countertransference. Combining the information from these sources gives us what's affectively dominant in each session, and there is where we start intervening to diagnose the dominant internalized object relations. That's one tactical element. We have ways of dealing with frequent complications, another tactic. Example, patients who are chronically suicidal. We make a differential diagnosis. Suicide because of depression, we treat the depression. Suicide without depression, characterologically based suicide, we tell the patient he has the task to control this behavior. If he can't control it, he can go to an emergency service, be treated, the treatment continues, or discuss it in the session. But he has to take the responsibility either to go to an emergency service or to present it to the session. We don't see him in between the sessions. That's his responsibility. If he doesn't fulfill that, we end the treatment. These are conditions we establish in each case. And of course, it depends how severe and what the kind of behavior is that we want to stop. But whenever we stop the behavior, it needs to be our stopping, it needs to be interpreted immediately in the transference as we start the treatment. The effectiveness of the treatment is the combination of control and interpretation of its meaning, systematic interpretation of this meaning. And that's a very effective technique. Another tactic. Third example of tactic. Patients who develop psychotic regression in the sessions, psychotic transferences, who don't have a psychosis. They have been well diagnosed as a personality disorder. We have a method of analyzing incompatible reality. Patient gets psychotic. For example, one patient became convinced that he was a physician in the same medical complex where I worked. He was convinced that I had forbidden all the nurses to have sex with him, all the nurses of the medical complex. It was totally crazy. But he was totally convinced and wanted to beat me up. So I pointed out to him that I believed the honesty and depth of his conviction. At the same time, I shared with him my conviction that that was complete madness without any basis in reality. I told him I didn't want to convince him of my conviction. If he believed me that I was not lying, if he thought I was lying, we had to analyze why would I lie to him. The patient didn't think I was lying, but that even without knowing it, I was making gestures so all the nurses knew no sex with Dr. So-and-so. So I told him, we obviously have incompatible reality. One of us is crazy, either you or me. We can't decide it. We don't have a witness. But we can decide that the matter is madness and analyze what it is all about. And what it is all about is that a powerful man interferes with another man's access to women. It's like a psychological castration. And that's the experience that we're talking about. And that brought to his mind memories of a violent father who had cut the vocal cords of his dogs because they were barking at night. I mean, a real sadist. And the patient was reliving emotionally that situation in that interaction with me who was cutting him off from all women. I'm giving you the briefest synthesis of complex issues as an illustration of specific tactical interventions. It is 2 o'clock. We have the treatment is manualized and available in its 3rd edition, published by American Psychiatric. The first author is Frank Yeomans, who directs all our educational operation. John Clarkin, who directs our research operations, and myself. So you can learn more about it in the text. Other ways to bring you up to date with what we are doing is end of this year, Yves Caligor will publish a book about psychodynamic psychotherapy for all personality disorder. That's going to be a very important book. I believe I'm not exaggerating, published by American Psychiatric Press. Diana Diamond will publish a book about narcissism, diagnosis and treatment, which will be the most complete study of the subject that I believe we have right now, that's coming out, published by Guilford, I believe, end of this coming year. And I have a new book coming out end of the year in which I will present that synthetic overview of psychoanalytic techniques that I talked to you about, an overview of diagnosis and treatment of severe cases of narcissism, and the dealing with erotic transferences and countertransferences at various levels of pathology. So we have these new things coming out in end of the year and the manual, and I appreciate your attention.
Well, I want to thank you very much for your really very impressive lecture. Many of us have read your books, and many of the present here obviously learned a lot, and will learn a lot after they start reading your books. And of course, I have not enough words to thank you for being here with us. We have a small souvenir from us for you, and a smaller one.
Thank you very much. That's very kind of you. Well, thank you. You have been able to be patient for 2 hours. That's pretty good. And I'm only sorry we haven't had a chance for more discussion and interchange, but I thought we just have to deal with realities.
In the conference.
Yeah, yeah.
Tomorrow, yes.
Yeah. Okay,
So thank
good.
you very much.
Thank you very much.
Good.
Wait, I will